We are, as part of this initiative that Trinity Unity Point has been doing to promote awareness about different cardiac conditions and heart-related issues. My talk is about atrial fibrillation. Atrial fibrillation itself is a huge topic, and we could probably spend hours talking about it. So today I'm going to actually narrow it down to a very specific kind of section or subsection within atrial fibrillation, which is how does atrial fibrillation play a role in causing stroke, um, and what are the options to deal with that specific problem. So just a little bit of background for me, about me. I'm a cardiac electrophysiologist. In a simpler manner, I am an electrician of the heart, unlike interventional cardiologists who are plumbers. That's the closest analogy I can find. I have offices in Moline, Silvis, Bettendorf, and Geneseo, and that's our beautiful office building in Moline. Now, before I start talking about atrial fibrillation itself, just for, I think, since the topic is such kind of highly selected version or highly selected part of atrial fibrillation, the talk is going to be brief, about 15-20 minutes or so, and then we'll take some questions. But in the meantime, if you have any questions, have a clarification to make, please jump in. Although we're doing this in a virtual format, let's try to keep this as casual as possible. So atrial fibrillation, or also known as AFib or AF, what is it? Can you see my mouse pointer hovering, Kathy?
Yes, we can.
Okay, so on the left, what you see this diagram, what's being shown is the heart has two upper chambers, a right upper and a left upper chamber, and two lower chambers. Normal heartbeat starts in the right upper chamber and goes down to the two lower chambers, and you have basically an organized synchronous heartbeat. In atrial fibrillation, what happens is instead of this organized electrical activity, you have upper chambers that are beating in a very chaotic, irregular fashion, causing the heartbeat to be irregular. And as we'll talk about further down in the presentation, it can cause blood to pool up into the heart chambers and become a blood clot and cause a stroke. And we'll talk about that more as we progress. Any questions so far? Although this is the first slide. Okay. So certain conditions or certain factors increase the potential for having atrial fibrillation. Some of the common ones are, as we grow older, patients or people with high blood pressure, even if it's controlled, diabetes, if you have any heart artery blockages or blockages, poor circulation in the legs, patients who have heart failure or whose kidneys are not doing too well and have chronic kidney disease, even if they're not on dialysis, patients who drink a lot of alcohol, and as always, smoking and obesity are big causes. Smoking and obesity seem to be high risk features for a lot of heart issues. Another very specific thing for atrial fibrillation is if thyroid is overactive, it can cause atrial fibrillation as well. And all of these increase your risk for atrial fibrillation as time goes by, with the result that atrial fibrillation is extremely common. In the US, it's estimated that by 2030, we'll have 12 million people with atrial fibrillation. That's a pretty staggering number. Again, as we talked about, as we grow older, atrial fibrillation or chance of getting AFib are higher. In people 65 years or younger, AF is relatively not that common, only 2%. But in people 65 years and older, the number jumps up to 9%, meaning 1 in 10 will have AF, atrial fibrillation. So again, we are kind of limiting ourselves to mostly overview of atrial fibrillation until we get to the stroke point. Atrial fibrillation is a huge topic to discuss. Atrial fibrillation or AFib can have certain consequences, essentially symptoms and adverse events. I'm sorry, someone's is paging me as well. So what are the symptoms of atrial fibrillation? When heart is beating irregular and fast, people feel palpitations. They feel their heart just racing along. Sometimes people feel shortness of breath. While those are fairly prominent symptoms, at times symptoms are not that clear-cut. Sometimes we see patients who just feel extreme or sudden fatigue. They were absolutely fine. They go into atrial fibrillation, and the only symptom they have is just, I feel tired. All of a sudden, I have no energy. At times, people have chest pain. And there's a big group of patients who at the beginning look like they don't have any symptoms at all. There are truly patients who have no symptoms. They are running around doing all their normal activities without any limitations at all. But a lot of people have just mild fatigue, not very prominent symptoms, which makes things a little bit difficult to assess if you have AF, atrial fibrillation, or not. Now, once someone has atrial fibrillation, certain adverse events can happen. Like we had talked about earlier, atrial fibrillation causes the chambers of the heart to beat irregularly, and a blood clot can form in any little pouch of the heart, and can cause a stroke or cause other problems caused by blood clot going to the leg or kidneys, for example. If someone has atrial fibrillation, they don't have prominent symptoms, and their heart rates are really fast for a long period of time. Eventually, the heart does wear out, and patients can get heart failure. Also, if heart has been beating really fast, it can cause heart attack as well. So while those are important aspects, the one thing we are going to focus on today is risk of stroke. Atrial fibrillation is a very big cause of strokes all across the world. In the US, more than 15% of strokes are caused by atrial fibrillation. And as we grow older, that percent goes up even higher. 1 in 3 strokes in people older than 80 are caused by atrial fibrillation. And of all the people who have atrial fibrillation, about 1 in 3 will have a stroke of some or the other kind in their lifetime. And those numbers are why we, whenever we see someone with AFib, the risk of stroke is always something to assess and address. Now, this diagram here is showing the heart, 2 upper chambers beating erratically in atrial fibrillation. A blood clot forms in the heart, breaks loose, goes up through this aorta, through the carotid artery, and gets lodged in some portion of the brain, causing a stroke. And that's essentially the mechanism of how AF, atrial fibrillation, causes a stroke. So considering the high number of people who have atrial fibrillation and the high incidence of stroke in atrial fibrillation, the question is, how to reduce this risk. And there are two ways of doing this. One is blood thinners, and the other is, and we'll talk about this, is what to do in people who cannot take blood thinners. So let's talk about blood thinners first. Blood thinners are also called anticoagulants. There are two classes of blood thinners. One is warfarin. The brand name is Coumadin, so you might hear people refer to this blood thinner as Coumadin as well. It's been around for about, I believe, 30 or 40 years. So it's pretty well known. We know how it works, what to do if the levels get too high, etc. The drawback of warfarin is you need to have blood tested on a reasonably regular interval. In the beginning, when we start someone on warfarin, blood tests are done about once every week. And then once a stable dose is discovered, it's done usually once a month or so. Warfarin does interact with some food items and medications, so people have to be careful about what they eat, and when they're prescribed any new medications, that sometimes can affect the warfarin level. So with all these problems, people were still managing until several years ago when this new class of blood thinners came along. So now they are no longer called newer because they've been around for a while. And these are Pradaxa, Xarelto, Eliquis, Savesa. All of them are brand names. Unlike warfarin, they don't need any blood testing done. Most of them don't require any major dietary modifications. The drawback is sometimes they can be expensive, depending on the insurance, copay, etc. But the advantage is it allows people a lot more freedom than warfarin did or does. And just to clarify, these are blood thinners. They are actually potent blood thinners. We are not talking about aspirin, Plavix, or clopidogrel in this context. Some people still call them blood thinners, but aspirin and Plavix are truly antiplatelet drugs. And with newer guidelines, they don't really have a lot of place in managing stroke in the setting of atrial fibrillation. So when in this talk, when I'm saying blood thinners, I'm referring to warfarin and these other ones, not the aspirin and Plavix. So most blood thinners are fine. Majority of people are able to take blood thinners for several years without having any major side effects. But some people do have major side effects of blood thinners, and that is abnormal bleeding. You can have a bleeding ulcer in the stomach and have bleeding in your stools, bleeding in urine, sometimes, and this is a very serious adverse effect or side effect, which is bleeding inside the head. That can at times occur even spontaneously without any injury. But obviously, if someone does get injured, the risk of bleeding goes up tremendously. So what to do in those patients who cannot take blood thinners for a variety of reasons? That's where this particular approach comes in, which is left atrial appendage closure or occlusion or exclusion. So first, let's talk about what is left atrial appendage and what is its role in stroke, causing stroke, and why even address it. This picture on your screen is basically a cutout of the front portion has been removed from this model. This is the right upper chamber, left upper chamber, right lower chamber, and left lower chamber. And this little pouch that's attached to the left upper chamber is the appendage. It's estimated that about more than 90% of strokes that happen in atrial fibrillation, the blood clot forms within this appendage and causes and goes up to the brain, causes a stroke. To address the risk of stroke in atrial fibrillation, this appendage, if it can be somehow blocked off, also called excluded, then the theory is strokes can be reduced, because if that's the major source of blood clots, then taking it out of the equation or picture should lower the stroke risk. That's what done during certain heart surgeries, like if someone is having a valve surgery, surgeons nowadays will frequently cut this appendage off. But obviously that's a minority of people who can have that particular procedure. For the rest, there is another option called WATCHMAN. Before we get to WATCHMAN itself, here's because I'll be using this picture later on, I wanted to kind of correlate. This is the appendage here, and this is the ultrasound image of that appendage. So this, what you're seeing here, is a left upper chamber, left lower chamber, and the appendage. So basically, this view is what you're seeing on the ultrasound. All right, so what is WATCHMAN? WATCHMAN, as you can see in this picture here, it's a metal kind of strut covered with a fabric. Of course, this is all medical grade. The best analogy I can find to explain it to patients without actually showing a detailed video is that this is a plug that's put in that appendage to seal it off. Putting WATCHMAN is a one-time procedure. There's no going back to retrieve it or repositioning it or anything that needs to be removed. Once it's in, it's in. The goal of WATCHMAN is to eliminate the need for blood thinners while reducing the risk of stroke, essentially in people who cannot take a blood thinner for a variety of reasons. So who might be a WATCHMAN candidate? Patients who have atrial fibrillation, who have had bleeding, major bleeding while taking blood thinners, or a group of patients who have a lifestyle or some occupation that puts them at higher risk of major bleeding, and they just cannot even take blood thinners for any sustained period of time. Obviously, not everyone is a candidate, but my perception is that over the next few years, this is going to become more and more of an option for more and more people. When we put WATCHMAN, our goal is to get people off blood thinners. A large trial was done to evaluate for this aspect. And in that trial, 96% of people were able to stop taking blood thinners at 45 days after getting a WATCHMAN implanted. Point to note here is it's not 100%. So there are still some people who get a WATCHMAN, and for if the device is not seated in a satisfactory position, they still need to continue taking blood thinners. But 96% is a very, very high number. Implanting WATCHMAN is a minimally invasive procedure. It's done through a puncture in the groin. We go up through the groin vein up into the heart, and this whole procedure is done through catheters. So there's no open heart surgery. There's no cutting involved. It's done under general anesthesia, primarily for patient comfort, although there are certain centers who, a few, not many, but a few centers who do it without general anesthesia. The procedure is heavily dependent on the anatomy of the appendage, the left atrial appendage. So sometimes it can take a couple of hours, but typically it takes 45 minutes to an hour. Patients stay overnight for monitoring purposes. We check in the morning, make sure everything looks good. And that's done with an ultrasound of the heart done from the outside, so just a regular echocardiogram. And if their blood pressures are doing well, groin is doing well, patients go home the day following the procedure. And this is why I was referring to this picture previously. This is the photo you saw, left upper chamber, left lower chamber. This is the appendage. And this is what WATCHMAN looks like once it's deployed in that appendage. This line, this white line that you see is the outline of the device. And this is actually my first WATCHMAN patient from last year, I believe January of last year. And he's doing great. It's an invasive procedure, so there are some risks. There are no invasive procedures without risks. The risks can be a risk of stroke if a blood clot formed on WATCHMAN itself went up and caused a stroke. During the implant, if the catheter perforates the heart, that can cause fluid to accumulate rapidly around the heart and might need surgery. Or the device itself can essentially pop out of the appendage and become what we call embolized, meaning it's no longer in the appendage, it's free floating and needs to be retrieved either through the groin or sometimes through open heart surgery. With current generation WATCHMAN, these risks are very small. This is a slide from a clinical trial called Pinnacle Flex, and the risk of stroke was 0.5%, and the other major risks were basically 0% in that study. And that's been generally the experience in most centers that implant WATCHMAN Flex, this newer generation WATCHMAN, which is quite safe and forgiving. So like we had talked about earlier, what happens after WATCHMAN implant? Patients go home the next day, usually. They do continue taking blood thinner for 6 weeks, at which time we do an ultrasound of the heart, make sure WATCHMAN is sitting properly, there are no blood clots, no fluid buildup. And if that's the case, then blood thinner goes away, which is warfarin or one of the other newer ones. We do keep patients on aspirin and Plavix or clopidogrel, which is the generic name, for 6 months. And then they only take aspirin. So at that point, stroke risk is low, and you're not taking a blood thinner anymore, which is a very desirable outcome. Until 2019, patients needed to go out of the Quad Cities area to get WATCHMAN device implanted. And early last year, one of my partners, Dr. Kovacs, and we started doing WATCHMAN at Trinity or Unity Point in Rock Island. And we're proud to say we were the first in Quad Cities to start doing it. So far, we've had good success and good results. And this is our fabulous team at Unity Point, Rock Island after the very first WATCHMAN implant. And everyone looks pleased, as they should. And at this point, I believe this is my last slide, and I'll stop here and ask if you have any questions.